Okay, good morning, everyone. Happy August. Glad to have you on here. Um, yeah, we're excited to be able to see you. I've been doing this for the last few months, just looking at a camera and having no visual feedback. So it's good to see all your beautiful faces. And um, let's get going. So today, just wanted to let you know that it will be recorded. It is being live streamed right now on Fresno County DBH on YouTube, and so you will be able to check it out later, and it will be open to the public. So just a warning on that. I'm going to share my screen with you and we'll go through a handful of slides. Give me 1 second. Okay. Okay. So there we go. Welcome. For today, when you have a question, you can utilize the chat feature in the comment section below, or you can just unmute yourself and ask any questions. There are a few presenters today, so it might be easier for you to just ask them without having to type it all in. Either way that you prefer, please do so. Okay. So our agenda today, I'm kind of excited about. We have a handful of presenters. The first one will be David Lopez with the Suicide Prevention Lifeline update. He's going to be going over the calls, the call volume at the hotline over the last few months and give us some updates on that. And then we'll have Ken Katz and Gilberto talking about the introduction of the CSSRS and the training guide that they put together. And we're going to show a video that he put together, which is fantastic. And then we're going to do updates on September Suicide Prevention Month, Awareness Month that's coming up here next month, and some of the things that we have planned virtually. And then we'll go over any announcements and Q&A. Is David on here? Do we see him? Yeah, he is. Okay. Thank you. My little windows got shrunk, so I couldn't see everyone. So I am going to hand it over to David Lopez over at the Suicide Prevention Hotline, and he is going to share a little bit. Hold on 1 second. Sorry, I'm having a hard time. Let me undo my share screen. Okay, sorry. And so David, there he is. He is going to share a little bit with you guys.
Yeah, good morning, everybody. I hope everyone's doing well, and thank you all for being here. So just to give you a little bit of preview of what's been going on at the Lifeline before we actually just get into the numbers, we've seen a dramatic increase in call across the valley itself, not only in calls, as long as like the amount of volume, but the actual call time is something that's increased, which has been a lot different, which means like the average handle time, what we used to have maybe a 10 to 15 minute call, now is turning into a 25, 35, 40 minute call. So each call is a lot more involved. And it's because one of the biggest things that we're seeing is that there's just a lot more compound and complex issues that we're seeing. So a lot of things that may have been just one stress point has been magnified, and a lot of people that may have had underlying mental health issues or concerns or stressors are now being exacerbated with the current conditions that we have with COVID, the social unrest, and just the prolonged social distancing that we're seeing. Some of the top things or new themes that we have been seeing has been an increase in calls from teenagers and transitional age youth, feeling like stressed out. So college age kids, not feeling like they're able to do or engage in what they wanted to do, not being able to engage in school, go and meet with friends. They're really feeling isolated and stuck, feeling like they're being shortchanged on the experience of a teenage life. That's causing them a lot of stress. One thing with the teenage mind that we know, they don't have the foresight or the around the corner thinking that some of us, as you develop and mature. And for that reason, it seems like this is all or none. This is never going to end. And my world is just, this is what I'm growing up in. So it's really causing their stress levels to increase a lot. And if they had any underlying stress issues before, it's exacerbated. A lot of another thing along just with the teenage crowd is their anxiousness for the future, and their hope has really deflated. It's not as much as it was before. And I believe that's just with all the media that the younger kids engage in, and what is actually being profound, and we don't have a solution to it. So one of the biggest things is instilling hope and validating where they're at right now. helping them try to at least see around the corner, even if it's a couple months down the road. Because we know with, teenagers or youth, they don't have that foresight, like I mentioned earlier. So when you do talk to them, you want to make it measurable in a way where it's not so far out, like years out, but hey, a couple weeks out or a couple months out, to just keep pushing it out a little bit further for them, and then change their focus. And the counselors and therapists in the room know would be on what they can do now, and help shift their focus to what they can do. Another thing that we've been seeing is a lot more stress from parents, and parents are calling in. One, and you can be a very compound, such as a family structure. Now everyone's forced to kind of interact more than they usually would. They don't have the normal outlets that they even could do or engage in a family. Some parents have called concerns. I was reading reports and listening to calls, and it's like, I don't even know what to do to entertain my kids. And I'm telling them that we can't go to Walmart, we can't go to Target. No, we can't go, because some of the expresses, some of their children have underlying conditions, diabetes, some people in the house, and we have to keep everyone safe. And to continue to tell children no is causing the parents anguish, and they're trying to look for solutions on, well, what can I do, or what do I do now? And so that's something else. So you're really teasing out a lot of different threads in each call itself, which makes it a lot more in time, that you need to spend with that individual. So the biggest thing that we like to look at is a one contact resolution, which means like, hey, if we can get them a lot of help and really de-escalate them and get them in a better space, hopefully that they could, if they do need to return and call us again, 100% call us. But really tease them down and then get them and give them some skills that they can work with, or at least get them over the hump until they can possibly get into treatment, link up to other resources. A lot of the calls right now that we're getting they don't have the suicidal content as much as we did. That's there. Maybe I shouldn't say that. The plan or means aren't there. It's more of a frustration, like, hey, I don't know if I want to go on like this. They're having passive thoughts of suicide. No real plan or no clear plan on a big bulk of calls. But it's there. So again, the symptomology is exacerbating, and it's something that we need to take concern and really take care with, because if this continues, or the longer this progresses, what once was a passive thought can become a progressive thought. And now it's every day, and it's frequent, it's increasing in frequency. And then now we're having, maybe a hospitalization or an attempt. And we really want to do our best to do everything we can to help stop that well. And using the term of our COVID-19, it's like, if we can flatten the curve of suicide as best we can, really try to do that, and to get them the help we can. It's one of the things that we talk about. We're in the middle of an event. It's a pandemic, right? Treating it as a natural disaster, and knowing that the next 18 months to 2 years are going to be our highest risks of suicide or death by suicide. So we really, as a community, I can't harp on everyone else. I know, thank you all for being here, but really rallying together and staying united and doing the best we can to help each other and help our community, because it's coming. And it's unfortunate that we can see it coming, but we have to do everything we can to help minimize that. With that being said, I'm going to share my screen on some of the last month's call data with Fresno County. And here's some good and some bad. So for the last quarter, we had 40 active rescues. Now that's the most active rescues we've ever had, and I had to double check to make sure. Usually that's inverse when we have more talk downs than active rescues. Now I'm speaking for the Valley, not just Fresno right now, but so Fresno had 16. That's high. So that means that our counselors could not work them down to a plan that was safe or a place that was safe for them at that moment, and we had to activate emergency rescue. Now, our procedure or our best practices, we always want to get them involved, and hopefully that they can agree to us calling law enforcement or EMS out there, emergency services, to help them. But sometimes we have to do it to preserve life without their consent, right? And so they may not be happy with that at times, because all of a sudden someone's knocking on the door. But most of all, if we can keep them on the phone and we don't have to go and find them, you can hear a little sense of relief. Ah, so-and-so's here. And it's almost like that deflation, like, did you call? Did you call? And we're like, yeah, we did. Sorry. And they're like, why'd you do that? And so it's like, well, we just want to keep you safe. Okay. And there's like a okay instead of like even like a outburst of anger. So that still gives me hope that they did call. We believe if they call us, they still have some sense of hope or semblance of hope. And we want to really magnify that every time we can have a contact with the caller. So I really am applauding my team, trying to support them as best they can. They're on the front lines doing the work. And I just try to do my best to instill as much knowledge as I can and support them on the work that they do each and every day. So going back, I'm going to share my screen real quick over here. Can you guys see that? It should be the call types, Fresno County data. Yes, I'm seeing some thumbs up. Yeah. Okay, so this is for July 2020. And what we're looking at is a total call volume of 781 calls for Fresno. Now, that is not normal. We usually harp around 500 calls, 150 calls a week. So the call volume has increased. Look at the call types here. So we had 592 crisis calls. Now, a crisis call can be classified as someone that has either emotional distress with or without suicidal ideation. So just to throw that out there. But then we had 8 top-down calls and 4 active rescues in a month. So that's something that's higher than usual. Again, that's kind of going on pace with 16 active rescues for a quarter. So again, glad that we were able to talk down more this time around. Maybe some people are settling in. One party calls 55, third party calls 34. So people calling in about their friends, trying to get information, things of that nature. And then miscellaneous, we had 89. Now that could be a tagging issue on our end because we have to input the data while we're on the call. But I'd have to dive deeper to figure out what that was about. So again, the majority of our calls are 76% are crisis calls, and that's where we're at. Here's caller concerns. Now on caller concerns itself, I just want to let you know the numbers that you see here will increase, or because a caller can have multiple concerns. It's not just I called in and I have a physical health issue or I'm having a mental health issue. They can also have a social issue with a mental health issue, so they can be often combined. It's not just one thing.
Hey, David, is there a way you can make it a little bit bigger? Perfect. I got the thumbs up over here. Thank you very much.
Yeah, for sure. Did everyone see the other data? Just going back since that was, we good here? Screenshot that maybe? All right, I'm going back. Okay. So the caller concerns, like I was saying, we can have multiple caller concerns because it can be a very complex issue. Suicidal content and mental health were almost the same on this at 28% and 29%. And that's, and then we have social issues at 23%, abuse, violence at 3%, general needs 10%, physical health 3%, and basic needs 4%. Luckily for this round, we haven't had no homicidal content, and that is something we have started tracking. And that's a lifeline best practice, and we can, if there's questions about that, I can further expand. For gender, we had 451 females call, 229 males call, 13 declined to state, and 87 that we couldn't know, or that we don't know the information on. And age 0 to 15, 47. Here's what I'm talking about, that increase of 16 to 25, 243. And that's from what we could track, right? Sometimes it's hard to get the age, and we try to do our best through the conversation to get it. This wasn't surprising to me. The 26 to 59, that's a very large range. I hope I could, if we could narrow it down. But the general adult population has increased for 292. Glad that they're able to reach out. But that's kind of fairly consistent of what we see across the board, that there's a a good amount of people. There's just more people that are 26 to 59. So just for that, 24 declined to state and 147 unknown. That's the data I have to share. Is there any questions about what I shared or anything?
David, could you explain for anyone who might not know the difference between a talk down and an active response?
Yes. So a talk down call, and the difference between a talk down and an active rescue is an active rescue is when the individual is in the act, has the plan, the means, and everything with them, and they have the intent to act upon it at that time. It's immediate. And we cannot get them to safety plan. So if they're in the act, either they took the pills already, they have the firearm, they're going to hang themselves, and there's no possible resolution or no willingness to engage in a safety plan, then we have to engage in, or we have to activate active rescue. When a talk down is everything, the scenario is the same. They have all the same intent, plan, means with them. However, we're able to disarm that plan via the counseling session over the phone. Get them to a safer place. Often we try to reach out to, even part of that safety plan, call us back. Hey, can we give you a call back within an hour? How about we can do it in a couple hours? You say, whatever it may be, but the same factors are there. However, we're able to get them in a safe place. They agree to a safety plan. It's their safety plan. We just help them develop it, right? Because it's really important that it's theirs. It's not ours. It's what works for them. And then we just support them on that, and then try to get them into connected to some sort of service wherever it is. That's the difference between the two.
Thank you. Does anybody have any questions? Thank you for all that data, by the way, David.
For sure. Sorry, it's a lull. We got a lot of stuff going on.
It's all good.
Thank you guys. I think I stopped sharing my screen. I'm gonna put myself on mute.
Does anybody have any questions for David? No? Okay. David, thank you very, very much. I appreciate it. We all appreciate it. Okay. Next, we are going to have Ken and Gilberto share about the introduction of the Columbia Suicide Severity Rating Scale, the training guide that they just developed for our county, which is fantastic. So I'm going to turn it over to them and let them lead the way.
Well, good morning. So I don't know if everyone is familiar with the CSSRS. We began talking about it at the collaborative maybe 3 years ago. And I was initially very enthusiastic about it. And then as Brandy knows, I kind of lost some enthusiasm about it. But I've kind of come to a place where I'm pretty supportive, because I think it's a very simple instrument that you just follow. You're really just asking 6 questions, and it helps you assess risk. We're not very good at predicting human behavior at all, but we can assess risk, and that's what this tool does. So I kind of wanted to develop a training guide that we could use for initially my vision was to use it for law enforcement, because we kept asking police departments to use it, but we didn't provide them any materials to help them learn to use it. So, but the more we've kind of progressed, I think it's generic enough to where anyone could use the training guide. And then we produced a video to go with it. We're going to show you both of them, but I want you to know that neither of them are completely done. And I hope to finalize both probably next week. But before we jump into those, Gilberto, did you want to add anything?
No, other than I think that you guys have done a great job, and I know it's been a long time in the making, and I'm glad to see it coming to fruition and that it's almost completed. So thank you for all your work.
Well, and I want to make a point that the training guide, I kind of began the work on it, but there's no way I could have finished it without Gilberto's assistance, and then feedback from some other people, including Brandy. So let's go ahead and put up the training guide. And both the video and the training guide at some point will be available on the Fresno Cares website. So if you could scroll to the top. So anyway, this is just some basic information about the CSSRS. And I also want to point out that the collaborative recommended the use of this instrument, and the Department of Behavioral Health supported that, and they took it to the Board of Supervisors, and the Board of Supervisors adopted it. So this is the tool that we would like used throughout the county of Fresno. And I think DBH has put some expectations on some organizations that maybe are funded by them. Susan, I don't know if you want to comment about that. Or not?
Yes.
So, oh, go ahead. Yeah.
So just to comment on that, it's a work in progress. We have set the expectation, but to the point you made earlier, Ken, setting an expectation and implementing a complete rollout plan that has all of the training and supports necessary to do it consistently and do it well, that's a work in progress. We have to, we want to enhance our electronic health record. We want to make sure that all of the various disciplines across behavioral health have the training because we know it's not just clinicians. So yes, we've set the expectation, but in full transparency, we have a lot of work to do. So we are committed and setting the expectation, and some parts of our system are further along than others. I don't know if Ahmad wants to contribute anything on that. Yeah,
in part of the work that this, Ken, is the first step in that we're working on the generic enough policy procedure for providers to then be able to take and morph into their own procedures and be able to take things such as this video, and then I'll touch later on. Our intern, Gracie, has also done a lot of work on vetting CCR's training videos. So we want to be able to put the whole package, as Susan said, so that when we tell them, hey, you need to now adopt this, it's not adopted and they can't implement it. It's like, it's now time for the adoption. Here's the information on how to do your policy and procedures. Here's the different the work that you and Gilberto are doing here, the training, here are all the things, because if not, our concern would be that they would have something and it would not be implemented. So all the work you guys have actually been doing this summer is to move us in that direction. So yeah, we before we kind of mandate it in some of their contract languages or in some memos, we want to make sure that we have all the work that you guys are doing, that we can also tell them, like, look, we're requiring this, and here's everything you need to be able to implement it. Because Ken, to Susan's point, we want this, and probably this training is going to be more useful for your non-clinical individuals to be able to do the screenings, to do that. And so we want to make sure that it's a way that's implemented. It's from a case manager, a peer support, everyone would have it. So part of it, the work has been waiting on the training you guys are doing, us getting those policy procedures developed. So we're much closer than we were even 3 months ago. And I'm hoping here that may be some of our larger collaborative goals, to set some timelines of, okay, now that we've got these resources and assets in place, when do we want to start kind of rolling them out and pushing them out? Susan, I don't know if that.
Yeah, it's a building block toward another strategic plan initiative, which is zero suicide. But we knew that getting to the zero suicide implementation plan was a really big initiative. So we're starting with the screening and then building in the training, and then eventually zero suicide.
Thank you. So let's go ahead and go back to the training guide. I do want to point out that this is there are a lot of versions of the CSSRS, and there's a very complicated one that's used for research. There's another one that's used for hospitals. So the one that we're using here is the screener version, meaning someone that would be using it, probably not a clinician necessarily, as Ahmad said, and they're just doing a risk assessment screening. And this really could be done by anybody. That's what's nice about this tool, is anyone can do it. It doesn't require mental health training or mental health background, but it does require training on just how to use the tool itself. So you can just, so let me just scroll through it really quickly. I wasn't going to go through it in any detail. This is what the instrument looks like coming up right here. And then at the very back of the training guide will be a list of resources to get more information about the CSSRS. Here's a lot of definitions that that are important to know the specific definitions so that when you're interpreting the CSSRS, you're using the right definition for understanding the behavior and the risk that's involved. And then just go down a little bit, Solomon, back up a little bit, I'm sorry. Just up to the next, the prior section. I just put in right there, a little bit about, again, things that a clinician may not be looking at this, just how do you ask questions? How do you do that suicide inquiry? Just some real basic information that I think probably comes second nature to most of us. And then the next section is the format of the instrument itself. And as I said, there are 6 questions. If you get a yes, if you get yes to question 2, then you ask question 3 through 6. If you get a no to question 2, then you can jump right to 6. So this is just breaking down each section. And I do want to point out how important the color coding is. Anything in yellow is considered low risk. Anything in, I call it orange. There's been a big debate where I work about what color that really is. Orange is moderate risk, and then red is high risk. And then these are triage points, or the risk levels, where again we point out the low, medium, moderate, and the high risk. And then we also developed, and Gilberto was really helpful with this, just looking at triage protocols in different settings. And it's impossible to come up with a protocol for every single setting. So we did, I think we did 3. This is triaging in a school setting, and then a community or law enforcement setting, and then finally in a hospital or healthcare setting. And there should be there. And then these are just some examples of answers we might get to the various questions. And so it's just a page of showing kind of what we shouldn't be surprised to hear these kinds of answers when they are answers in the affirmative. And that's the training guide, real short. This is the instrument. It's its own page so that it can be copied and reused. There is no copyright on the instrument. The Lighthouse Project has made it publicly available. In fact, it's available not only in the United States, but all over the world. It's been done in 103 languages. So I didn't want to just do the training guide because I think it's also helpful to read something, but to see something. So we put together this video, and I again want to emphasize the video is not done. And if any of you have done videos of yourself, I don't like seeing myself. Maybe other people don't like seeing me either, but anyway, this is the video, and I really want to give kudos to John Mark Bergen, who is our multimedia specialist at American Ambulance. I think he did a really good job on the video.
Hello, my name is Ken Katz, and I'm here representing the Fresno County Suicide Prevention Collaborative. And I'm here to talk to you about the Columbia Suicide Severity Rating Scale, also known as the CSSRS. Let me talk for a minute about the scope of the problem of suicide. Every 15 minutes, someone dies by suicide in the United States. Suicide is the second leading cause of death in children. It is the third leading cause of death in adolescents ages 15 to 19. and it is the fourth leading cause of death in adults. Suicide is the second most common cause of death in the United States military. And in Fresno County, we average approximately 2 deaths by suicide every single week. On average, approximately 112 Fresno County residents die by suicide every year. The good news is suicide is preventable, and it is hoped your use of the CSSRS will help identify those most at risk for suicide and will help get them the care and treatment they need. So let me talk a little bit about the CSSRS itself. The CSSRS uses responses to 6 questions to guide your decision making with regard to the level of suicide risk. You are encouraged to read the questions as they are written to ensure the proper information is obtained. It rates suicidal ideation of increasing severity from a wish to die to an active thought of killing oneself with a plan and intent. The answers help users identify whether someone is at risk for suicide, assess the severity and the immediacy of that risk, and gauge the level of support that the person needs. It's important to pay attention to the color coding of the yes answers. Anything in yellow is considered low risk, anything in orange is moderate, and anything in red would be considered high risk. And then there are examples following that of the triage protocols in different situations or settings. The first one is in a school setting. The next would be law enforcement or a community setting. And the last example would be a hospital or some other healthcare setting. This will help those authorized to initiate involuntary psychiatric holds to determine if the person warrants being placed on a Welfare and Institutions Code 5150 or if referrals should be provided. And this will help those evaluating individuals but not authorized to initiate a hold to determine if the individual should be evaluated by someone who can write a hold. Typically, the subject can provide the best information about their suicidal thoughts and intent. However, any and all sources of information are acceptable. The CSSRS is evidence-based through research and is widely used throughout the United States and around the world. In fact, it has been translated into 103 languages. It's suitable for use with adults, adolescents, and young children. The CSSRS does not require mental health training to use it, but it does require training on how to use it. Accurate and consistent use of terms and definitions leads to a more accurate interpretation of the CSSRS. Therefore, beginning on page 2 of the training guide are terms and definitions that should be kept in mind when completing the CSSRS. Please review these definitions before utilizing the CSSRS. And finally, it has a brief administration time. Okay, so let's look at how to utilize the CSSRS in practice. After introducing yourself and taking a few minutes to establish some trust and rapport with the individual, you would start out by asking questions. Questions 1 and 2 address suicidal ideation. Question 1 says, have you wished you were dead or wished you could go to sleep and not wake up? Question 2 says, have you actually had any thoughts of killing yourself? If the answer to 1 and 2 is no, you'd skip and go all the way down to question 6. If, however, the answer to number 2 is yes, then you'd answer 3, 4, and 5, as well as 6. Question 3 addresses suicidal thoughts with a method, and it asks, have you been thinking about how you might do this? For example, I thought about taking an overdose, but I never made a specific plan as to when, where, or how I would actually do it, and I would never go through with it. Question 4 and 5 address intent. Have you, question number 4, have you had these thoughts and had some intention of acting on them? As opposed to, I have thoughts, but I definitely will not do anything about them. And question 5, have you started to work out or worked out the details of how to kill yourself? Do you intend to carry out this plan? And finally, question 6 addresses suicide behavior. Have you ever done anything, started to do anything, or prepared to do anything to end your life? You must always ask question 6 because it specifically asks about suicidal behaviors. A suicidal individual will be more inclined to answer your questions honestly if you are able to take time, listen attentively, and establish rapport and demonstrate empathy and concern. The suicide inquiry is best approached as an interview, or even better, a discussion, rather than an interrogation. Speak openly and frankly about suicide and let the person know you are genuinely concerned about them and their safety. Research has shown that when we ask people if they are thinking about harming themselves, they said no. But when the same person was asked if they had thoughts of killing themselves, they said yes, because in their mind, killing themselves would actually relieve pain, not bring them harm. Thank you for taking the time to listen to this video and learn about the CSSRS. If you're interested in learning more, please take a look at these resources. Thank you.
So that's the video and the training guide. Again, neither of them are finished. I noticed on what got edited out was I pointed out when we did the video that there's actually two parts to question 6, and the second part has to do with how recent was the behavior. And the CSSRS looks at the most recent 3-month period in terms of high risk. So anyway, we're going to try and edit that back in, but glad to hear any thoughts. And before this is done and put on the website, it will be shared again with the collaborative steering committee just to make sure everyone supports the finished product.
Ken, thank you so much. There is a question for you. There's also some kudos, so make sure you read those when you have time. But there's a question here that says, if a home visitor develops concern about a family member, where would they refer such a screening? Can home visitors be trained virtually now on CSSRS?
Yeah, I think it's a tool that absolutely could permit virtual training. And frankly, hopefully with the training guide and the video, you could do it just based on those as well. But I could see a virtual training being completely workable with this instrument.
And Brandy, like I had mentioned, our intern Gracie, who's on this call, she actually went through and vetted all the existing CSSRS videos because Columbia had them on YouTube. So they have ones that are 24-minute long trainings. There's ones that are 2 minutes. They have ones for military. All those ones. They even have the ones in Ken said it's translated in numerous languages. They don't have a video for every language, but they do have in about 20 some odd different languages. So she's actually gone through and we're going to bring that to the steering committee. So she went through and vetted like every video, broke down what every video is, what the population is, how long the lengths of the videos are, and just kind of the benefits. So I think in combination with the work that Ken's done and having all these resources available on the website, people can download, like Ken said, the tool is free. We'll have even more links on the website, but people can go pick the screening tool, watch a quick video. I think, Ken's video works, but if they need one in a different language, they can watch that video and be able to have an understanding of how to do that and be able to do the screen. So that was one of the reasons why we as the committee work group, sought the collaborative sought the CSSRS, because anyone can do it. You don't need any kind of professional training, and it is basic enough to where it guides you. It's not like, okay, here's the info, what do I do next? It's color coded to where you must, yellow, you must do this, orange, you must do this, red, you must do this. I would say probably one of the things we'll probably add maybe to the website and Ken, I know we'll probably do I know we're working on the PP, on the policy procedure guide, but maybe on the video is to answer Brooke's question of saying, hey, if you screen this and, you land on, whatever it is, red, that your next step is to call, crisis, or call the lifeline, or call for the actual appropriate screen, because it doesn't do much to have that and go like, oh, I don't know what to do. It's red, so do I just leave it? The next thing is to call, the Central Valley Suicide Prevention Lifeline, and maybe it's the instruction, and you don't have to put all that in the video, but I think that might be one of the things that we may want to plug in is like, hey, if you respond to this screen or you have any concerns, call the Lifeline number. That might be something on a video, and then we'll definitely work those into the policy and procedures to give people next steps. One of the things that we're writing into the PPG scan too, that you talked about is making sure that people are using the screeners, if they're using it in color, because if you print these sometimes in black and white or grayscale, especially with that orange yellow, it's kind of hard to look and tell and be like, what color am I in on a grayscale? Because I've tested it on grayscales, and on lesser quality copiers, it can become really hard to see. So we're making some of those emphasis like, hey, if it's a school, if it's if it's print, some color copies and have them available. But David, I saw his hand up, so I'm gonna shut up now and let some experts speak.
I just wanted to go back to Ahmad talking about the videos. So I also looked at all the videos, and a lot of the content of this video came from those videos. And I was kind of frustrated because I didn't see any 2-minute videos. I saw 18 to 25 or 30-minute videos. And for what my eye was police department briefings, and I knew they weren't going to look at a 20, 25-minute video. That was a concern. But I also really want to encourage everybody to go to the Lighthouse Project website, because they have training certifications, and you watch some videos and take some quizzes and you get certified. And but there's a lot of really good information about the CSSRS on the Lighthouse Project website.
Perfect. Thank you. Are there any other questions? Brooke, I know you had a follow-up question. I know that you're going to have links at the end of the video for people to kind of be guided further. But Brooke, do you have other questions?
Right. Who is the contact person to set up training with, if needed? And when will the video be posted? Because I can send folks there to review to see if they feel like such a training, to make sure that such a training would be helpful to them.
So what I hope is that both the training guide and the video will be done next week. It'll go to Solomon as finished products. And then what we hope is that they'll be posted on the Fresno Cares website.
Right.
And if you know, there will be a link on, not a link, but maybe it is a link on the website to go to training. And so, someone could go and say, oh, where's a training on whatever, the CSSRS? And either Solomon or Ahmad, I don't know if you want to comment, if someone sees something and they want to get a training on a specific date or time, how that would work.
I don't know. We've actually looked at that was part of the thought of creating the videos and some of the training guides, is that it is something that anyone can go onto the Lighthouse Project, for example, and just download a screener and do it. That was the whole intent of using this tool.
I could do the training myself. I mean, I could train them. That's a possibility.
Yeah, I mean, the videos and some of the guys that we've created, and even there's one, I think, Gracie, like a 2-minute demonstration even on the CCR's video that she's identified. So there's multiple things that people can go and watch and just basically do the screen tool. That's the advantage, and I think the beauty for what we were able to do with this, that it doesn't need you don't have to have a train the trainer type model. It's
okay.
Really, and what I hope is on the Fresno Care website that there will be links to the some of the videos and other training materials from the Lighthouse project. So yeah, I think you could do the training yourself.
And Brooke, like Ken said, on the Lighthouse project website, they have additional what is the word I'm looking for? Steps to where someone can watch some of the videos, do the demonstration, be able to get even the certification on that. We do have on the Fresno Cares website a page dedicated to trainings, and those ones right now are the larger trainings that do need a trainer, suicide talk assist, things like that. But CCRS will be on there, and we can definitely design it with the video can actually be on there, as well as links to the Lighthouse and some additional. So really what we wanted to do with this is to make maybe they're a provider not in our network. So I'm thinking like a group home, and they come across, hey, this is a great tool. Can they easily train their staff that are probably part-time, that are students that you can't afford to have them on a clock for 8 hours to do a training, but they could watch it. And also for parents, just, parents to be, if they're concerned, a family member, loved one, you can jump on here, grab the screener, watch, the video, kind of get a little idea on what to do, the demonstration, and do it. And I think you make the key point of making sure that we highlight and really prominently feature of like, if you need the additional step, this is the number where you need to call next. Because that's what you don't want to have someone to do, that where they're kind of rudderless. Okay, now what? It's like, if you have, or even kind of saying, even if you don't have like a concern, but you have a question, it didn't come red, but it's yellow, but you're still kind of concerned, call the number, get the information, do the check-in, have, David's team that are pros at this be able to say, you know what, you're okay, or you know what, tell me more, and be able to ensure that we really start trending, flattening the curve and getting that number down. So.
Thank you. There is a question from Rocio asking if there'll be a flyer as well. I think that obviously you can go to the Fresno Cares website. Solomon will be sending out all of the information once it's complete and final to everyone in the collaborative. So you will have that accessible in your email. So there answered that question. Are there any other questions for either Ken or Gilberto?
Brandy, I just wanted to comment, and again, I'm a visual learner and I like to keep things simple, and so I think Ken and his team did a really good job of doing that walkthrough, and just taking it step by step. And so, Brooke, it would make it really easy to have anybody be able to go through that training, and then be able to administer it, or at least disseminate the tool, because it's very simple and straightforward, and that's what we were wanting to do with this tool, is make it as simple as possible and user friendly, so that anybody can really use the tool out there. So I think that having the training guide and the video along with it will help individuals out there to be able to easily use the tool.
And again, this,
great job, guys, on that. That's awesome. And just Brooke and everyone else out there, it's really the individual's comfort level with asking those questions. And that's why having that guide is there, because it actually gives you some questions to ask, which is hard for someone to start that conversation. And that's one of the most difficult things. So using that, and it's having specific questions that you can ask. Of course, building rapport is the most important, but then it's allowing the individual to follow something that has a semi-structured format to it. There's no right or wrong way to deliver it, but it just is asking that actual question that you need to do that gets the individual to answer a question, right? And then again, if you're feeling your own gut and intuition is if you feel that and you're still like, hey, I don't know if this is true or not, have them call a lifeline, call them with us, and then we can talk to them right then and there, just throwing it out there.
Great, thanks.
And to David's point, sometimes that I have found that people feel more comfortable to where if you say call the lifeline, they're maybe reluctant or they're just not sure what to do. And sometimes just saying like, hey, you know what, I'll call with you. Like, are you okay with me calling with you? We'll put it on speakerphone, and almost just having that conduit to him of someone just being the like, I'll dial the number, we'll put on speakerphone, I'll be right here with you. Like, I'm not leaving your side. And having that security makes people okay, because I think sometimes for individuals calling that number is not the fear of calling the number, but it's now we're going to basically rip the Band-Aid off potentially. And I got to tell them what's really going on. And I'm maybe embarrassed and I'm kind of scared and just having someone there say, hold the phone and say like, look, I'll call with you. Like I'll stay on with you. And that will a lot of times encourage and sway people to have that initial intervention that we're looking to do. So,
yeah.
And if you're not calling with the client, but you just want some guidance or some additional information, you're not sure what you're dealing with, another resource that our behavioral health medics rely on a lot is the Department of Behavioral Health Access Line. So again, it's just good to know about all the resources that are available.
Yeah, and just so that all of you know, the home visitors just had a substantial substance use training, and that definitely included the access line and all of that. So they got a lot more comfortable, and this ties into that. So yes.
That's awesome. Really big thank you to Ken and Gilberto. They've been working on this for a few months now, and you guys did fantastic. I think you knocked it out of the park in the video. Ken, you're like another Hollywood. You and David are going to be. So thank you very much for that. And I'm excited for the resource that you're providing for the county and just the guiding. I think sometimes it feels a little overwhelming when you don't know what to do. So I think you guys knocked it out of the park. Good job. Any other questions before we move forward?
I was just going to say, I think having this video now will help the work that Gracie and some of our teams have been doing in terms of putting together the policy procedure too, because now they have a visual of what the guide and the training videos are all, and they can also include, say, hey, here's where you may get some additional, here's how, because the question a lot of times for people is, where do I start? How do I do it? And we're trying to package as much of a generic framework of like, here's everything you need to implement this in your organization or department stuff. Thank you. That's really useful. And having read the work that Gracie and the team have done on the policy and some of the other stuff, I'm like, okay, we can totally blend all this stuff into like literally having a starter kit for agencies. Like, where do I start on CCRS? Here you go. Adapt it to make it work for your organization.
Exactly. Okay. Thank you guys very much. Okay, moving along on September Suicide Prevention Awareness Month, we will be doing a virtual, I'm kind of excited about it. We have a committee formed, and we've been working on it for the past couple months. So on September 1st, there will, there's obviously the Prevention Proclamation and Loss Team update to the Board of Supervisors. And that information on what the Loss Team was able to, how they were able to serve this community in this first year is pretty phenomenal. So we're excited to share that with you. As far as the event, so what we're going to do, we are going to release a video some weeks, well, every week of the month, but some weeks we'll have multiple videos every day. One every day for the entire week. And there'll be videos each week. And so there are people throughout the community who are jumping in on this with, NAMI, with David over there, with survivors of suicide loss. There's a couple high schools getting involved. So it's going to be a wide array of people who are chiming in. It's really exciting. A couple of things that the first week, I think Chris is leading that video, Chris Roop over at NAMI, and talking about different trainings that are available throughout the month for your agency, for your own selves, including youth, mental health, first aid, ending the silence, talk saves lives. And then Heinz Hospice has a Understanding Grief workshop that just went onto YouTube. And so you're able to access that. Usually we do that in person, but now with COVID, everyone can jump in online and just view that from your own home and just get a better understanding of grief and all the signs or the symptoms and kind of how to take care of yourself. And then the second week, we'll be doing a suicide prevention awareness mini series. And this is going to be a 360-degree view of suicide. So we're going to have videos from those with ideation. I think David's chiming in on one of those. Attempt survivors, success stories, and survivors in the loss team. And so these will all be short little videos, kind of just giving you an entire view of suicide as a whole. So I'm really excited about that. And third week, we'll have virtual wellness workshops. And I think there's meditation involved in that. Chris or Lisa, you can jump in anything I'm forgetting. I'm just getting the nod. Okay, so I think I covered that. But be looking out for those, and there'll be more information to come. If you or your agency has any trainings that you will be providing in September or moving forward, please go to Fresno Care's website. There's a little button, I believe, at the top where you can click on it. Yeah. And you can get your training on the calendar so that anybody in the county can get on there and know when the next training is available. But please let Brian know, and it'll get on the calendar. And we'd love to have that updated before September 1st so that when Chris kind of releases all the information and the trainings for the month, we would have yours available. So please, if you have any trainings or anything, or resources, please let us know. Fresno Cares. Oh, there's a chat. I can't see because I'm sharing my screen. Hold on.
The question is, how will
Thank
the
you.
community learn about all these opportunities?
Yeah, so there will be videos sent out through the collaborative. They will all be live. I think we'll have some social media posts. You can always go, no matter what, whenever you have a question, you can always go to fresnocares.org and be updated on any information that's coming out. And we will be releasing those videos the first week, and then the second week of September, which is actually Suicide Prevention Week. We'll have a new video every single day that week, so be looking for those. And they'll be posted on DBH Facebook. Lisa, you want to chime in with where else they'll be?
Brandy, I just, the point in my question really was, you know, all of us that are in the loop, we know to go to Fresno Cares, and, but how will the general public that might be interested, but if they don't naturally go to Fresno Cares, how will they learn about these things?
So we're going to create some videos, especially on the training that Chris is going to be doing. It's going to be like an overview of all the trainings, and we're going to push that out to social media and direct them to Fresno Cares.
Okay.
And Ken, part of the September suicide prevention campaign that the department is going to be doing with our partners through JP is also trying to direct, basically the action item for a lot of the content is going to be call the lifeline if it's something like that, or go to the Fresno Cares website as well. So those will be things that will also be digital ads, potentially some TV ads, radio ads. We just had a call this morning where they're trying to work all that on the next couple of weeks to get those out. So part of what we're hoping to do is also some mass marketing to drive people to the Fresno Cares site as well.
Perfect. Thanks.
And also just to piggyback on that, anytime that Solomon sends out information covered in the collaborative, we strongly encourage everyone to just pass it out to their agencies, to their people on their mailing list, just to continue to spread the word. So if you're in a school, please pass it off to your colleagues, you know, wherever you're at, please let people know. Because you're right, Ken, if they're not involved in the collaborative, people might not be aware of the Fresno Cares website. So please be our feet in our mouths and spread the news. Okay, let me go to, okay. Suicide Prevention Awareness Month. There is a suicide prevention summit that has been hosted by SLO County, Kern, Tulare, and Fresno, and more information to come on that, but there will be a live Zoom that's an all day, I think it's a Wednesday, did we say? Is that September 9th is a Wednesday? Yeah. And then there'll be 4 suicide related sessions, and we have a few people here. I think Chris is leading one, Noah Whitaker from Tulare County. I think maybe Stan Collins might be doing one, if you're familiar with him, down south in San Diego. And Chris, I think you're on the speaker panel. So there are a lot of familiar faces, but a wealth of knowledge. So make sure that you tune into that. There will be links and more information to follow on that as well. And then additionally, kind of the same story, more information to follow on Each Mind Matters in California Department of Education are putting on their own webinar series. Will be held during September to recognize Suicide Prevention Awareness Month, and more info to come on that. Okay. And then I can't, so Chris, can you read me a question? I can't see it when I'm sharing my screen. There's chats.
Georgiana from Fresno State says Fresno State has plans for the week, but they will only be open to Fresno State students. Would that still be helpful to list on the Fresno Cares website? Definitely.
And then we could for sure, you know, delineate that it's for Fresno State students, but please, any information that is an activity or some sort of event going on, please share it with us. And Brian says, just tell us in your, when you post it on the Fresno Cares website, just tell us the who, what, where, when, why, any cost or anything like that. So get all the information and Brian will post that all on the website.
Okay, can do. Brian, what's your last? Sorry.
His name is Brian Bishop.
Thank you.
There's a button, right, on the Fresno. Yeah, he said just use the contact form on the Fresno Cares website.
Okay.
Are there any other questions, Chris?
No.
Okay, thank you.
Thank you.
Yeah, thank you. Okay, so there will be a drive-through resource event that's location right here. It says Clovis High and Central High School. That is to be determined. We're still finalizing locations. But the reason that those two sites were chosen is because Clovis High School and Central High School are located in the 2 zip codes highest for completed suicides in Fresno County. And so we wanted to make sure that those communities, like Clovis High is 93611, Central, I can't think of it right off the top of my head, but if you live there, you know it. But we wanted to make sure that resources are provided to those communities specifically. So if you have anything that you would like to contribute to this resource fair, whether it's, so it's going to be people drive through. They did one earlier in the spring. Was that early? Yeah, spring. People can drive through, pick up a bag of resources. It has information on mental health, addiction, substance use information. So if you have any information or promo items that you would like to have included, please get a hold of Solomon, and he will make sure to coordinate with you to get all those in these bags. So that, again, is more information to follow, kind of just finalizing those sites and times and all of that, and days. So send us your events right here to Fresno Cares website. Do we have any questions on that?
No.
No, got a thumbs up. Okay. Before we go into Q&A, I did want to just let you all know that the next meeting will be September 4th. Location, it'll probably be right here, is my guess, but it'll be same time, and more information will be coming out on that as well. And if you ever have any questions, please contact Solomon Bang 24/7, and you can email him or give him a call, but he's kind of the keeper of a lot of information, so he's a great resource. And let me go back. Oh, okay. Any questions?
Ahmad, you wanted to share something, a legislative update?
Yeah, just sorry, I've already exceeded my word count for today. But AB 2112, which was introduced by Assemblyman Ramos, which was actually to push forward the suicide prevention plan that the OAC had established, specifically calling for a state Office of Suicide Prevention to live within the California Department of Public Health, had started. And with COVID, it was one of the bills that was kind of shelved for a minute because it wasn't those priority. A lot of the bills that the legislature took up had to do with COVID relief and then budget and things that had budget issues. But that is actually a bill that was reintroduced and picked back up. And I'm wondering if, it's conjecture at this point, but the spikes that we did see on deaths by suicide, if it highlighted the urgency of continuing work on this. I know the information I think that DeJuan shared with our suicides in June at a media call with COVID got traction, and we had a lot of local coverage on that, and then we were getting calls from national publications and things like that trying to get information on Fresno's data. So bottom line with the AB 2112, it's actually cleared the Assembly. It's gone over to the Senate. It's cleared its first committee in the Senate, and it's going to now go to the Budget Committee. That's where there may be some questions. You're bringing on an idea to establish a new office at a time when the state is running a $50 billion deficit. So we don't know how that'll come out, but they may establish that office and just put on hold on when it would assume work. But it's one of the few suicide bills that's actually moved forward this year. And that one would be, like I said, to establish the Office of Suicide Prevention under the Department of Public Health. It would be under Dr. Nadine Burke-Harris's charge, and really starting its initial focus on suicide prevention amongst our adolescent and really trying to address some of the trauma. They won't be limited to that, but that's where they're kind of starting. So we just learned about that late yesterday, early this morning, that bill is alive and back in the mix. So just wanted to pass that along so you guys can follow it.
Thank you, Ahmad. Also, Each Mind Matters suicide prevention toolkits are available. They're usually in the back of the collaborative, and Solomon hands them out to folks. But if you would like one or a couple for your organization or school or agency, please contact Solomon. It is first come, first serve. And I know that there's activities involved in there. There's little tent things. There's a lot. So I don't have one in front of me, but there is a lot. There are a lot. And contact Solomon if you would like one of those. And then, let me see. Are there any other questions? Is there a toolkit for first responders?
More information, not at the moment.
Solomon says, not at the moment, but more information to come, Ken.
Yeah, they said that last year too. I don't mean Solomon. I mean, Glenn Matters said that.
They're pretty general, the way that they create them, just so that they can get the most use out of them. But those are definitely feedback that we do give as far as areas that we think with some of the toolkits that could be more specialized, specializing ones for school versus in general first responders. But yeah, they have kept them pretty general. And I'm going to just be honest, amidst COVID, I don't know if they've done a lot of, have had a lot of opportunity to kind of create new content. I know they've been looking and following issues, but those may be some things that we can say, hey, since it is COVID and you guys aren't doing other things, maybe they can start specializing some of those. I don't know. We'll ask.
You know what, Ahmad, when you do ask, and I think I've had this conversation with Stan as well, but the suicide rate amongst first responders is almost double that of the general population. So when we talk about a high-risk population, I think it warrants some attention.
Agreed. Thank you, Ken. Just a little note, because I do get this question quite a lot. As Ahmad had mentioned, Dewan did do a kind of an announcement back in July regarding the suicides that we had in June, because we did have a high number. We did have 17 in June, which is the highest number that I could find in months past. Thankfully, in July, we had 4. Obviously, that's 4 lives too many, but we did have a significant decrease. And as of today, for August, we're at 1. So hopefully it continues to decline, but thankfully we did not see a repeat of June's. Let's see, Michael said, even though kids are starting school at home, will the schools be doing suicide awareness training in September online? I think I saw Trish on here earlier. Trish, can you, not to put you on the spot, or Farah?
Yes. Hi there.
Hi.
Hi. My guess is that we don't actually, have the schools report to us what they're going to be doing, but my hunch is that they will be. We've got some virtual formats now for suicide training for teachers that we've gotten through AB 1808. We've gotten a whole group of licenses that we're going to be distributing. It's not enough to cover all the middle and high school teachers in our county, but yeah, I'm sure that there'll be trainings. And Farah, are you on?
Yes, she said.
Okay, we're also going to make a video too ourselves, and we're actually collaborating with Fresno Unified and Clovis Unified. And so together we're going to get the people who do the assist trainings and the safe talk trainings for their districts to put together our own training that's going to be unique to Fresno County, that we're then going to get out to all of the schools so that they can use that as well.
Perfect. Thank you, Trish. Farah said no video, no mic. So that's the way.
Oh, that's right.
You have no responsibilities.
That on purpose.
Yeah, she's smart.
She is smart.
Any other questions? I'm on the call with, okay. Okay, Ahmad just said he's on a call with CD.
So I'll get more info on the one that was mentioned, the CD, but they were looking at doing a series of webinars, and they had one that was pretty successful last year or last spring, Trish, that CDE had done. It was like a webinar for parents. Stan was part of it, and they did an English and Spanish one. And because of the success with that one, they're going to offer that again in September as well, geared towards parents in English and Spanish as well. So as soon as we get info on what CDE is doing, we'll pass that out to everyone, but also provide those links and things too.
And Ahmad, the one that they are giving to us to deploy to the schools is a Living Works program called START. And it's an interactive virtual training that's intended for school staff. And it's 90 minutes, and it's a pretty good training. It's really intended for not people who are mental health professionals or counselors, but it's really intended for any person who works on a school campus who needs to have an awareness of how do I respond to a student and how do I talk to a student who may be having thoughts about suicide. And one of the groups that we're deploying it to is the folks in the after school programs.
Yes.
They work for Fresno County Superintendent of Schools, but they actually are deployed out to all the sites across the county. So we're going to be training a whole host of them. So we're really excited about that, because a lot of times that's where kids really start to talk about how they're feeling is to their after school program folks. And the after school programs are still providing services. They've had some adaptations on the way that they can expend their funds and the activities that they can do. So they're going to still be out there working with kids and making contact and supporting them, even though we aren't going to be physically on campuses.
And we did something similar about like 6 years ago with one district in Kingsdale after school program where we trained them in mental health first aid, because they were spending sometimes, 10 hours a week with the kids. And because they were not the teachers, but they were an adult, sometimes they formed a different rapport. And so it's just a way for them to maybe identify or look at like, what, Susan's demeanor has really changed in the past week. What's going on? Like, because they sometimes observe things differently than maybe that teachers don't. And so that's a fantastic idea of giving that training to those after school folks, because if nothing else, they're now aware.
Right.
But they also can kind of be a screener now too. Go like, you know what? I'm concerned about this, or this just seems kind of odd that this student or child has changed and being able to intervene. So that's an awesome idea.
Yeah, and that training, that mental health first aid training has, the time is reduced. There's 2 hours of pre-work that they do on their own before they take the course. And then the online, it's virtual, it's 4 hours. So it could be realistic to still continue giving that training to them.
Hey, Ahmad, on the CDE webinars that they're putting together for parents in English and Spanish, is that content stuff that we can gently steal and have our colleagues that can maybe produce that in Hmong for our Hmong community, since that's a threshold language here in Fresno County? Can we liberally borrow?
I'm trying to remember to last year, because I think it may have actually even been originally developed by Each Mind Matters and maybe pushed out that way. So we can check, but there shouldn't be an issue. The reason I think they went with English and Spanish was some of the members of the committee, and I think it was San Diego County Office of Ed was the one that presented that, and so they had Spanish speakers. But I don't think there would be any issues with us asking if they would allow us to maybe adopt the information, the curriculum, to try to translate it Hmong. I'll ask that for sure next on the next call. Good idea.
Okay, that'd be great. Thank you.
I like your wording of gently stealing as opposed to just blatantly. Perfect. Okay. Any other questions, comments, or events or announcements that anyone in this Zoom has to share?
Could I just make a kind of a statement / it's not really a question, but
sure.
Everybody that's involved in this work are sort of natural healers and helpers. And in this pandemic, self-care is really critical for everyone in this global experience. But I know that for helpers and healers and compassionate people, sometimes prioritizing our own self-care is really hard. So I just want to kind of put it out here to all of us. Mostly I'm talking to myself because I'm not really great at that. But we are really focusing a lot within our leadership team on this concept of resilience and how important it is for us to recognize our own resilience and celebrate that. And I just wanted to put it out here to all of you in this important work to make sure that you're prioritizing yourselves as well.
Definitely. Excellent. Valley Children's Hospital is doing the same. Thanks, Michael. Yeah, awesome. Good reminder. Anyone else? Okay, if there's, perfect. Sounds like everyone's trying to get on that train as well. So good job. If there are no other questions, if you do have a question, actually, you could always email Solomon, right? 24/7 we talked about, and or call him. And he will send out an overview of everything that was covered today. Be looking out for announcements following for the links and the videos from Ken when the final copy is completed. Be also looking from probably Lisa, I'm guessing, and DBH for all the announcements coming with Suicide Prevention Awareness Month and all the events and the virtual videos and everything that we have planned for that. And yeah, it's really good to see everyone's faces. I miss being together, so it's good to do at least Brady Bunch style. And yeah, happy Friday, happy weekend. And for all you headed back to school, big high fives to all the teachers who are trying to navigate, and all the administrators who are trying to navigate what this is going to look like right now. So yeah, thank you, everyone. Stay safe, take care, and we'll see you in September.
Thanks, Brandy.
Bye, everyone.
Yeah.